Rheumatic fever can develop following an infection of streptococcal pharyngitis, commonly known as strep throat. However, it's important to note that not everyone who contracts strep throat develop rheumatic fever. Only about 3% of individuals with strep throat progress to acute rheumatic fever. This condition is more prevalent among children and young people living in poor and overcrowded areas. The progression from strep throat to acute rheumatic fever involves several steps. Strep throat is caused by Streptococcus pyogenes, also known as Group A beta-hemolytic Streptococcus. This bacterium produces an enzyme called streptolysin, which can lead to the lysis or breakdown of nearby red blood cells, or hemolysis. In laboratory culture media, some strains of Streptococcus result in complete lysis of red blood cells around bacterial colonies, a phenomenon termed beta hemolysis. In contrast, alpha hemolysis causes partial damage to red blood cells. Some strains of these bacteria have a matrix protein, called M protein, on their cell wall. This M protein is highly antigenic, meaning it triggers a strong immune response in the body, leading to the production of antibodies against it. However, there's a catch. This M protein bears a striking resemblance to proteins found on certain cells in our own body, such as those in the myocardium, heart valves, joints, skin, and brain. Consequently, the antibodies generated to combat the bacterial M protein can mistakenly target and attack our own cells. This phenomenon, known as molecular mimicry, leads to a cytotoxic reaction or type 2 hypersensitivity reaction. Contrary to what one might expect, acute rheumatic fever isn't directly caused by the bacteria themselves. Instead, it arises from the immune system's response, which typically occurs 2 to 4 weeks after the initial bacterial infection. Once antibodies have latched onto our own tissues, immune cells attack and destroy them. This process releases cytokines, which in turn activate more immune cells to continue the assault on more cells. The outcome is cell death and fibrinoid necrosis. The necrotic area becomes surrounded by T lymphocytes and reactive histiocytes. These histiocytes, known as Anichko cells, exhibit distinctive nuclei resembling caterpillars. When these elements come together, forming a granuloma with central fibrinoid necrosis surrounded by lymphocytes and Anichkov cells, they're termed Aschoff bodies. During acute rheumatic fever, the immune response targeting various organs and tissues leads to a range of clinical symptoms. The most prevalent symptom is the occurrence of monoarthritis or migratory polyarthritis in the large joints. Migratory polyarthritis refers to joint pain that shifts from one joint to another. For instance, pain might start in the knee, then move to the ankle, then to the hip, and so forth. Multiple large joints become inflamed, swollen, and painful for about a week, but typically resolve within 3 to 4 weeks without causing permanent damage. Around 1/3 of patients experience pancarditis, which involves inflammation across all 3 layers of heart tissue. Pancarditis includes endocarditis, myocarditis, and pericarditis. Endocarditis involves inflammation of the inner lining of the heart, including the heart valves. The mitral valve is commonly affected, although the aortic valve may also be involved. Myocarditis refers to inflammation of the myocardium. Inflamed areas within the myocardium may contain Aschoff bodies. Myocarditis poses a significant risk, as it can impair the heart's ability to contract effectively, potentially leading to heart failure, making it the most common cause of death in acute rheumatic fever. Pericarditis, on the other hand, involves inflammation of the outer covering of the heart. This inflammation can cause chest pain and may produce a characteristic friction rub resulting from the inflamed layers of the pericardium rubbing against each other. In addition to joint and heart issues, the hypersensitivity reaction in rheumatic fever can affect various other tissues. Some patients may develop painless nodules under the skin, known as subcutaneous nodules, typically found on the extensor surfaces of the limbs. Another characteristic manifestation is erythema marginatum, a reddish rash appearing as rings on the arms or trunk. Autoimmune reactions against the basal ganglia of the brain can lead to Sydenham's chorea, characterized by rapid involuntary movements of the face and arms. This symptom usually manifests late in the disease, at least 3 months after infection. These 5 manifestations are the major criteria for diagnosing rheumatic fever, known as the Jones criteria. Additionally, there are minor criteria that can help in diagnosis, such as fever, joint pain, and elevated levels of acute phase reactants, proteins that increase in response to inflammation. During inflammation, fibrinogen causes red blood cells to aggregate, leading to faster settling at the bottom of a test tube, a phenomenon known as the erythrocyte sedimentation rate, which may be elevated in patients with rheumatic fever. Furthermore, due to heart-related symptoms, patients may have a prolonged PR interval on ECG. The clinical diagnosis of acute rheumatic fever requires either 2 major manifestations or 1 major and 2 minor manifestations. Additionally, there should be evidence of a preceding infection with group A beta hemolytic Streptococcus, typically confirmed through a positive throat culture, rapid streptococcal antigen test, or blood tests indicating elevated levels of anti-streptolysin O or anti-DNase-B. Only about 20% of cases exhibit a positive throat culture during acute rheumatic fever. Management of acute symptoms in acute rheumatic fever primarily involves anti-inflammatory treatment. Aspirin and non-steroidal anti-inflammatory drugs are effective in promptly controlling joint symptoms. Antibiotics, such as penicillin, are used for eradication and prevention of subsequent episodes of streptococcal infection. This preventive measure is very important because repeated exposure to group A beta hemolytic Streptococcus can trigger immune attacks against various tissues, particularly the heart tissue, potentially leading to chronic rheumatic heart disease. In chronic rheumatic heart disease, the mitral valve and occasionally the aortic valve are damaged due to repeated inflammation. This results in the development of scar tissue, causing thickening and fusion of the valve leaflets, a condition known as commissural fusion. Additionally, the chordae tendineae, which attach to the valves, may also become thickened. These alterations in valve structure can lead to mitral regurgitation, where the valves fail to close completely. Over time, this can progress to stenosis, resulting in a narrowing of the valve opening, sometimes referred to as fishmouth or buttonhole stenosis. These roughened areas also increase the risk of microbial attachment and invasion, a condition known as infective endocarditis. As recurrent episodes of acute rheumatic fever contribute to the development of chronic rheumatic heart disease, a key objective is to prevent acute attacks. This primarily involves reducing recurrent streptococcal infections. Depending on the severity of symptoms and tissue damage, patients may require prophylactic antibiotic treatment for a very long time. This could range from 5 years in patients without carditis to anywhere from 10 years to lifelong treatment in those with established rheumatic heart disease.